Hello everyone, today we'll be talking about basics of airway suctioning. Suctioning is possibly the commonest procedure performed in ICU, however no one talks about this procedure. The principles and utility of suctioning is often misunderstood. So in this lecture we'll discuss the evidence and practice behind the most routine thing that we do in ICU. Most of the content is taken from recent publication from American Association of Respiratory Care in 2022. So as we learned before, there are two ways of direct clearance therapies. One is suctioning and other is therapeutic bronchoscopy. One of the things to understand is using suctioning, you can only remove secretions from the very proximal airways. The distal airways cannot be cleared using this method. Before we start, let's understand the complication of this procedure. Suctioning can reduce the lung volumes and that can result in atelectasis and oxygen desaturation. Suction can result in trauma to airways. Suction can result in transient tachycardia or bradycardia. It can result in transient increase in blood pressure or hypotension. Suctioning can also stimulate arrhythmias, elevate intracranial pressure, occasionally can cause pneumothorax, and increases the risk of infection. When the patient is on the ventilator, they are delivered definite tidal volume. However, when you suction, you remove some part of the air during the suctioning. So part of the air does not reaches the alveoli, and this would increase with increasing the diameter of suction catheter or increasing negative suction pressure and increasing the duration of suction. So suctioning results in multiple physiological changes. Most important thing, it results in loss of surface area, also known as atelectasis. This will cause shunting and can cause hypoxemia. This will stimulate hypoxemic pulmonary vasoconstriction, which can increase RV afterload and hypotension. This can result in reflex bradycardia or tachycardia. Suctioning can also irritate the receptors in trachea and bronchus and can cause elevated blood pressure and tachycardia. Stimulation of vagus nerve can result in bradycardia and hypotension. So suctioning is not a benign procedure. Protocols must be in place to take care of your patients. Hypoxemia is the commonest complication after suctioning. In most cases, this will stabilize in about 5 minutes, but if not, you would possibly need to recruit the atelectatic lungs. So either you can give them recruitment maneuver or some respiratory therapist will manually bag them, and hopefully you would have increased your FiO2 to 100%. So first question, when should you suction? Studies have found that as needed suctioning is as effective as routine suctioning. So whenever you hear crackles in your breaths and you think that there are secretions fluttering in the airway, if there are visual secretion in artificial airway, if you see sawtooth pattern on vent waveform or find signs of increased airway resistance, you should go ahead and suction. By this time, you should be pretty good at identifying increased resistance in the airways. If not, watch my previous lecture on airway resistance. But in brief, you can look at the following 4 things on the vent waveform and figure out if there is increased resistance in the circuit. You can look at capnogram, expiratory flows, time constant of alveoli, and peak minus plateau pressures. Closed or open system for suctioning have similar results in terms of safety and effectiveness. A Cochrane meta-analysis on this topic showed that risk of ventilator-associated pneumonia, mortality, and length of ICU stay were no different between closed and open tracheal suction systems. The closed tracheal system, however, produced higher bacterial colonization rates. However, this was not associated with increased risk of ventilator-associated pneumonia. Superficial suctioning is the suctioning just beyond the endotracheal tube. This is where most of the secretion will pile up because of blockage of the mucociliary escalator. In deep suctioning, you insert the suction tube till the resistance is met and you pull back by 1 centimeter and then suction on your way out. This is to get more distal secretions as suction catheter goes beyond the tip of endotracheal tube. This has more propensity to cause trauma. Superficial suctioning is associated with slightly lower rates of changes in mean arterial pressure and SpO2. Discuss with your respiratory therapist what kind of suctioning you need for a given patient. When performing deep suctioning, your catheter has a tendency to go into the right side more often. You can increase the chances of going to the left side by turning your patient's head to the right side. There's no studies comparing sterile technique versus clean technique. However, sterile technique is the most common thing that we use in our patients. Pre-oxygenation is important as it will prevent your hypoxemia after suctioning. Increasing the tidal volume before suction does not prevent hypoxemia. However, using 100% FiO2 is not a must. Just use enough FiO2 to prevent desaturation after suctioning. Usually, most of the hypoxemia after the suctioning will resolve in 3 to 7 minutes. The size of suction catheter should be less than 50% of internal diameter of your endotracheal tube or any other airway like tracheostomy. If you use larger size suction catheter, these will be more difficult to insert and will cause more discomfort to your patient. This will result in higher heart rate and systolic blood pressure. The other important thing to understand is it can reduce the tidal volume due to decreased airway for volume delivery. So more air is removed by the catheter because its diameter is bigger, and less air can go in because the effective airway by which the tidal volume is going in is decreased. This will result in higher degree of atelectasis and hypoxemia. This is really important in patient on pressure control or pressure support modes, so be very cautious while suctioning in these modes. Make sure that you keep your suction pressure less than 200 millimeters of mercury in adults. Using higher pressure will result in higher amount of air removed from the lungs and can cause more suction trauma. So use the minimal amount of suction needed to remove secretions. Longer suction period will result in more air removal from the lungs and decreased tidal volumes. However, nobody knows how long the ideal suctioning time should be for. However, less than 15 seconds is generally accepted by most experts. A lot of us use normal saline lavage during suctioning, and the advantages include loosening up of secretions, increasing the volume, and prevention of plugging. However, this comes with a couple of adverse effects. It results in increased amount of oxygen desaturation, bronchospasms, and elevated ICP and dislodgement of bacterial biofilm on the inside of the artificial airway. The comparison between normal saline and no normal saline did not show any difference in drop in oxygen saturations or any more complications. So normal saline installation before suctioning does not really benefit your patients. As per AARC, you should perform the saline lavages sparingly and you should not be using it routinely. Couple of other suggestions. Do not suction while you are going in, as your suction catheter is going to stuck in more proximal tissues and can cause trauma. Start suctioning once your cath is in and use the suction on your way out. Use intermittent suction using thumb control rather than a continuous suction, because intermittent generates more turbulence, so it gives you better suctioning capacity. Intermittent suction will prevent suction trauma from sucking in the tissues and will not result in excessive drops in tidal volume. Always allow 15 seconds before repeating the suction. Always make sure that you stabilize the endotracheal tube when withdrawing the catheter. If you do not, you may dislodge the endotracheal tube from trachea. Always lock the suction control valve, because sometimes it can get accidentally pressed and start suctioning air and can result in decreased tidal volumes. In summary, PRN suctioning is as good as scheduled suctioning if you are vigilant about the secretions. Sterile technique and closed systems are preferred. Pre-oxygenate before suctioning. Use saline lavage only if needed. Superficial suctioning is routine in most situations. Use deep suctioning only when required. Make sure that the suction catheter is less than 50% of airway diameter and your suction pressures are kept less than 200 cm of mercury. Duration should be less than 15 seconds. Use intermittent technique and wait 15 seconds before repeating the procedure. Always make sure that you stabilize the endotracheal tube when withdrawing the catheter, and watch tidal volumes during pressure control and pressure support modes during suctioning. Monitor oxygen sats, heart rate, and blood pressure. Thank you.